Good afternoon. I am Sarah Dash, President and CEO of the Alliance for Health Policy. For those who are not familiar with the Alliance, we are a nonpartisan resource for the health policy community dedicated to advancing knowledge and understanding of health policy issues. Welcome to the sixth event in our COVID-19 webinar series. The Alliance for Health Policy gratefully acknowledges the National Institute for Healthcare Management Foundation and the Commonwealth Fund for supporting today's webinar. You can join today's conversation on Twitter using the hashtag AllHealthLive and follow us at AllHealthPolicy. We want you all to be active participants in today's webinar, so please get your questions ready. And I'm going to give you some quick technical notes on how you can ask them. You should see a dashboard on the right side of your web browser. Select the speech bubble icon with the question mark to chat with us about any technical issues you might be experiencing. You can also use that icon to submit questions that you have for the panelists at any time. We will collect these and address them during the broadcast. Later today, you will also find all of the materials that accompany this webinar on our website, along with a recording of the webinar. As the COVID-19 outbreak continues to escalate, Congress has been working around the clock to pass legislation to stimulate the economy and support the healthcare system as it responds to the COVID-19 outbreak. Today, our panelists will review actions that Congress and the administration have taken to date and discuss what we can expect in the coming weeks and months. Now it is my pleasure to introduce our panelists. First, we have Andrew Rosenberg, co-founder and partner at Thorn, a leading bipartisan government affairs firm. Andrew has 25 years of experience as a lobbyist, Capitol Hill staffer, and health policy lawyer, and previously served on the Senate Health Committee. Next, I'm pleased to introduce Billy Wynne, chairman of the Wynne Health Group, a national public interest health policy consulting firm. Previously, Billy served as health policy counsel to the Senate Finance Committee. Billy, Andy, thank you both for joining us. Now,
thank you, Sarah.
I'm going to hand it off. Great. Andy, I'm going to hand it off to you first for some opening remarks.
Fantastic. Thank you. Happy to be here, everybody. Why don't we get straight to the slides? We can jump into we've had three phases. Well, actually, we've had two COVID bills passed so far. There's so much content here, Sarah. I want to sort of get right into it. So I'm going to describe the first two phases of the bills, of the legislative response, which have already gone through Congress. And then I'm going to talk about the third one, which is literally on the floor of the House of Representatives as we speak. And then I'll talk about plans and prognostications about a fourth or maybe even a fifth corona package might look like. But let me start here with phase one. So phase one was an $8.3 billion package that seems like ages ago. It was only a couple weeks ago, and it was actually 3 times what the administration initially asked for. It combined new funding for treatments for COVID-19, public health agencies, and community preparedness, and had a waiver of restrictions on Medicare telehealth coverage during the outbreak. It included $3.1 billion for vaccines and therapeutics and a diagnostic development fund, $300 million in contingency funding for vaccines, therapeutics, and diagnostics, $2.2 billion for the CDC, a paltry $1 billion for the SBA, the Small Business Association, and $1.2 billion for the State Department's response to the outbreak and for global health and stability programs. It all seems rather quaint in hindsight, just a couple weeks ago. It also included sort of a drug pricing element. This was maybe the most controversial aspect of this first package because it, in providing money for funding for vaccine and treatment therapies, there was an effort made to put some restrictions on what companies could charge for those vaccines or cures. What Congress decided to come up with, where they sort of met in the middle, was sort of a statement of existing law, which was that the government purchase of coronavirus therapeutics, vaccines, and diagnostics must be made according to the Federal Acquisition Regulation guidance on fair and reasonable pricing. So nothing terribly controversial came out of it, but it was momentarily a point of some contention. There are also provisions in that first phase on telemedicine, like I said, authorizing HHS Secretary to waive some telehealth restrictions in the Medicare program, as well as some language around the Public Health and Social Services Emergency Fund. Then came phase 2. Next slide, please. Phase 2 focused on FMAP, providing states with a 6.2% increase on traditional FMAP for all medical services during this public health emergency. It does not apply to expansion or administrative FMAP. However, there were limitations. It is conditioned on, and that boost is conditioned on states' Medicaid programs covering COVID-19 related treatment, vaccines, and therapeutics at zero cost sharing, and on states not making their eligibility standards more restrictive or increasing any cost sharing. There was also a technical correction to phase 1 bill on Medicare telehealth. There were some worker protections. The package required employers to provide 2 weeks of paid sick leave and up to 3 months of paid family leave for employees that were affected by the virus, the cost of which could then be claimed by the employer as a tax credit. And then also under social safety net section, the package, this again is phase 2, provided for $1.25 billion in supplemental assistance for those impacted by the epidemic, including $500 million for the WIC, for the Women, Infants, and Children program, $400 million for emergency food assistance program, $100 million in nutritional assistance to the territories, and $250 million for senior nutrition programs. Finally, testing. This was probably the key element of phase 2. The package required insurers to cover COVID-19 testing without cost sharing, and it waives cost sharing for testing under Medicare, Medicaid, TRICARE, and the VA. It gives states the option to cover testing and related services for their uninsured populations at 100% FMAP. Moving now to phase 3, which is the bill that is currently on the floor of the House of Representatives. This is the big one. This is the $2 trillion package. First, I'll mention that it wrapped the Medicare extenders package, which was set to expire on May 22nd, into this bill to reauthorize the extenders through November 30th of 2020 of this year, so into the lame duck. In part, that was done because, quite frankly, Congress doesn't know for sure when they're going to be able to get back to Washington after they recess later today. So that punts the extenders. The bill also places additional requirements on drug manufacturers with regard to healthcare shortages, so that they must be reporting their supply interruptions and to maintain contingency plans to ensure a backup supply of their products. There's also a $100 billion fund for the PHSSEF, or Public Health and Social Services Emergency Fund. That is allocated to reimbursing providers for expenses or lost revenue directly attributable to COVID-19. It also included a provision related to over-the-counter OTC reform, and you've probably heard the big stuff on the news about the direct payment relief, which provides recovery rebates of up to $1,200 for individuals, $2,400 for married couples, and this rebates begin to phase out for incomes of people of $75,000 and above. Checks would include $500 per dependent child. And then further, the tax year 2019 payment deadline has been extended from April to June 15th. Finally, it also includes small business loans, that sort of forgivable loans to small businesses with 500 or fewer employees. Those loans are designed to cover payroll, mortgage payments, rent, and debt payments from March through June, so 3 months. And those are forgivable loans, meaning essentially grants to small businesses in order to maintain their work staff. Next slide, please. This is quickly the sort of just to remind you of the dates that this was all done. This is all in the last couple of weeks. Phase 1 was signed into law on the 6th of March. phase 2 on the 18th of March, and then phase 3, literally it's being on the floor of the House of Representatives this morning right now as we speak. Literally minutes ago, Thomas Massie, a renegade Republican of Kentucky, demanded a roll call vote of the House of Representatives, and they are right now scrambling to see if they have enough people to make quorum, which would be 216 present members of Congress. As of late last night, leadership was scrambling to get their members back and on the floor so that they could have a vote. And it remains to be seen whether or not they have enough quorum to get that done today, or if it needs to be passed tomorrow as a result. Next slide, please. And my final slide is that this is probably not the end of it. There's already conversation, there are already plans being made for what a phase 4 or possibly a phase 5 could look like. This package would include, additional supplemental funding for agencies and technical corrections. Speaker Pelosi already noted that funding for food aid, stronger worker protections, and funding for pensions in state and local governments will be prioritized by Democrats in the next round of COVID-19 response legislation. That said, I want to leave room for time for questions and for Billy Wynne. So Sarah, I will hand it back to you.
Great. Thanks, Andy, for that terrific overview. Let's jump right into Billy's slides. Billy's going to talk more about the regulatory response. Billy, take it away.
Thanks very much, Sarah. And thanks again to the Alliance for Health Policy for having me. It's a pleasure to be with you all. Thanks, everybody, for participating. Why don't we move on to the next slide? So I just quickly wanted to note a few things that are unfolding, as we speak. It may have changed since I finalized these slides. But the first is that while the president had invoked the Defense Production Act, which gives the government authority to require private commercial manufacturers to prioritize the manufacturing of products necessary for the national emergency, he had not done so prior to the commencement of this call, although there's been active discussion about doing that. The president has preferred to pursue private negotiations with companies using the DPA invocation as a lever in those negotiations. They have secured a certain degree of protection equipment and masks, although frontline responders would quickly tell you there are not enough in the field yet. And while they have not secured an agreement to produce ventilators from private companies, seeing just kind of right now that there may be some announcements later today. There's been some dispute between the president and most notably the governor of New York regarding the number of ventilators that are needed at the moment to meet the healthcare crisis. Secondly, as I'm sure everyone has observed and is experiencing, states and localities have been issuing varying degrees of stay-at-home or social distancing orders, restricting business functions to those deemed essential, et cetera. The president has had mixed message on that posture and has recently been openly ruminating on the possibility that some of these restrictions, at least in terms of the federal guidance, could be relaxed by Sunday, April 12th. But I think clinical community, including some of his own advisors, would disagree with that prediction. And I believe at the end of the day that we'll see, it's going to be an ongoing evolution of the decision-making process. And I wouldn't invest a lot of certainty into that April 12th date at this point. Last of all, some states have begun issuing or opening special enrollment periods for the Affordable Care Act exchange coverage option. The federal government had not done so. To be clear, loss of employment is a qualifying event that would enable someone to enroll in an ACA covered plan, including to pursue eligibility for premium and cost-sharing subsidies. So this is really for those who chose not to enroll in the regular enrollment period, but now may have contracted COVID-19 or may fear that they or their family members will contract it and would like to get coverage. So that's what this special enrollment debate is about, and about I don't know, approximately 35 states. People need to go through the federalhealthcare.gov to access those exchange plans and subsidies. So we are watching closely to see what they do there. Next slide, please. So there has been a host of regulatory guidance and announcements that have come out of the Center for Medicare and Medicaid Services and others. I'm not going to read through all these. I understand these slides will be posted to the Alliance for Health Policy website after this call is over, so definitely welcome folks to access them there. I just want to note a few things that, for example, with regard to the commercial insurance industry, CMS has been issuing guidance regarding the coverage of COVID-related diagnosis and therapy as essential health benefits under the Affordable Care Act, also pre-deductible coverage, for example, for high-deductible catastrophic plans for these services. So commercial insurers are quickly, on the receiving end of implementing this new guidance, and I can tell you that there's a good bit of sort of confusion, and like everybody else, we're sort of working with these adjustments to standard policy in real time. CMS has also issued directives for providers, for example, allowing them to enroll in Medicare temporarily, to relaxing the state restrictions around licensing, and trying to minimize the bureaucratic processes providers face in getting waivers of coverage for services for their patients. They have also issued a recommendation that non-essential services, non-essential surgeries be postponed unless patients are in very acute need of that type of care. And most hospitals, as far as we have seen, have been complying with that and turning their focus to patients infected with COVID or potentially infected. Next slide, please. So I mentioned earlier, and I know you had a call earlier about masks and protective gear. The CDC, in addition to the White House-led efforts to procure and distribute those materials, the CDC has been issuing guidance to providers on how to care for patients presenting with COVID symptoms and suggesting some alternatives when the recommended materials are not available. There have been substantial relaxing of telehealth requirements. Medicare historically, as many of you know, has had very restrictive rules and guidelines around use of telehealth services, primarily out of the fear that it would expand cost and discretionary services. Within the Medicare program, at least, the access to that has been greatly expanded temporarily, commensurate with the timeline for the declaration of the national emergency. We can get back to that in more detail if folks would like in the Q&A. Why don't we move on to the next slide in the interest of time? So I just want to note that clearly access to testing has been a challenge in our country, and there have been numerous efforts by the FDA in particular to try to promote the expansion of approved tests and recommended tests to determine COVID infections. Those processes are ongoing, and commercial companies are rapidly, pursuing potential new approaches, including at-home testing, et cetera, that we'll see if they can come to the market in the next few months or so. Similarly, there is a lot of effort to pursue both treatment for patients infected and also vaccinations for prophylaxis. Kevzara, for example, you see here on the slide, has been used for autoimmune deficiencies like rheumatoid arthritis. So there are some existing therapies that folks are pursuing approval of for application to the coronavirus. There's also novel therapies that are being developed by some companies, and the FDA has been working with them on fast-track approval where that's appropriate. With regard to states and Medicaid, CMS has promoted the use of waivers to relax provider and other restrictions that have been implemented at the Medicare level, but the federal government doesn't have authority to do at the Medicaid level. And several states have begun to pursue those avenues. They can, for example, again, relax restrictions around provider enrollment in the Medicaid program. They can relax perennial confirmation of patient eligibility for nursing home, access to services there, and home health, and a whole host of different services are eligible for eligibility and access relaxations if states choose to apply. And many states, I think the number is now more than 13, have done so and received approval of their waivers from the federal government. Next slide, please. I think that's it. I just want to close by noting that we are making all of our COVID-related analysis free. If you go to wynnehealth.com and navigate to our blog, you'll get access to a range of materials there. So certainly welcome folks to take advantage of that if you'd like. Thanks again for having me. Appreciate it.
Great. Thanks, Billy. And thanks, Andy. So we've already gotten a bunch of great questions from the audience. So if you do have a question, please feel free to send it in through the chat bubble. But we're going to dive right in the 10 minutes or so that we have left. So first, let me ask you, Andy, on the extenders deadline, which had previously been May 22nd, now, as you say, pushed to the lame duck. There had been aspirations of maybe tacking on legislation around drug pricing, around surprise billing. Do you think those get done in the lame duck? What do you think?
Yeah, great question. I mean, there was an awful lot riding on, or potentially riding on, that May 22nd deadline. I mean, I think that there was a lot of sort of obviously Grassley and Pelosi to some degree had sort of, I think, a shared interest in using that as an opportunity to get some of these things done. I'm not sure if Mitch McConnell saw it the same way, but May 22nd was certainly going to be a bite of the apple, so to speak, around some of those and other a range of extraneous healthcare issues that we're looking to ride on that vehicle. We understand that while Grassley, I think, very much wanted to have another opportunity this calendar year to deal with some of those issues, which is why it was punted to November, that actually the request came from the White House to choose November of 2020 rather than to push it to 2021 to have that deadline extended to, which Pelosi and the Democrats were happy to accede to. It does raise a lot of questions and concerns if you're in pharma and you want to avoid a conversation around drug pricing for as long as possible, as well as some of these issues on surprise billing and other related Medicare issues. Very possible that it could ride in a lame duck. That's always sort of been the concern or been the opportunity, depending upon how you look at it, all along, that lame duck sort of loomed as that possibility, and I think it remains that way.
Great, thanks. We have a couple of questions around telehealth, so I'll open it up to Billy first, and then Andrew, if you want to jump in. One question is very specific around whether the telehealth provisions permitting coverage in HSA plans before the deductible are temporary, just through 2021, or permanent, and whether they include all telehealth, not just related to COVID-19. And then there's a related question, which is whether you all feel that there's any appetite amongst lawmakers to sort of make any of the healthcare-related provisions permanent, lasting beyond the emergency, and specifically mentioning telehealth. So kind of a compound question, but if you'd like to take a crack at it, go ahead.
Sure. This is Billy. So with regard to are all services covered? Yes, essentially. I mean, so those that can be performed by telehealth, it is not restricted to COVID-related services, and that is a part of the kind of social distancing strategy, in addition to the kind of COVID treatment-related strategy. My understanding with regard to all of the relaxation of telehealth standards is that they are temporary and permitted under the President's declaration of a national emergency, and will be rescinded with the rescission of that national emergency when that day comes. Having said that, to your kind of third part of your question, Sarah, the there's been a growing interest and movement in the market prior to all of this toward telehealth. I would be surprised if all of the restrictions in total are rescinded at that point, given the additional traction that will be given to, again, even non-COVID related services. And I think, as in many other aspects of our lives, we're recognizing that some things we've depended on face-to-face encounters to accomplish may not be as necessary through face-to-face channels as we previously thought. I think telehealth is a great example of that.
And I would agree with everything Billy said. And I would just say, yeah, I mean, there's no question, but COVID is providing an opportunity, almost a demonstration opportunity in some regard for some of these ideas and these technologies and approaches. I think that stakeholders would be wise to tailor their request to the current emergency so as not to appear to be taking advantage of the situation to further a longer term objective. But that said, looking into the crystal ball, you can't help but be aware that if there are some good lessons learned from this experience around telehealth and other remote care sort of scenarios, that there could be grounds for further expansion of that.
Great, thanks. So I'm going to try to get to as many of the questions as possible. There's a question around coverage of testing. So in the phase 3 legislation, was there any provision to make plans cover non-FDA approved tests for coronavirus? And understanding this is still very fresh legislation.
Not non-FDA, Billy. I didn't see anything that would sort of cover anything that wasn't FDA approved. Billy, I don't know if you have.
Oh, sorry, I was muted. I agree, Andy. Nothing that certainly not mandated. Clearly there's some kind of ambiguity around off-label use of some of these items, but no, certainly no mandate to use non-FDA approved items.
Great. So now we have a couple of questions relating to hospitals. There's a narrow question and a broad question. One is whether there was any mention of permissible community benefit expense reporting for the not-for-profit hospitals treating COVID-19 patients and other public health response. So was there anything around community benefit reporting? And then a much broader question, which was an implementation around the $100 billion fund for health services, for health systems, which was, a prognostication. How quickly do you think that HHS or CMS can turn around guidance and regulations to start making payments from the $100 billion fund to hospitals and providers? Community benefit and $100 billion.
I can do the community benefit, at least try. I have not seen something related. I think it's an excellent question, and I think that there are certainly going to be community benefit, requirement related ramifications of this and how hospitals report their activities under, the COVID response. But in terms of any formal guidance or new reporting requirements, et cetera, coming from the federal government, I have not seen any.
And my only response on how quickly the $100 billion, I mean, I know that, or I believe that the administration has essentially announced that all of these rulemakings that are going to be coming out as a result of, and guidances as a result of these COVID-19 bills will not rely on a comment period. They will all be expedited. That, which obviously makes it more important to get in there and try to, share your insights as quickly as possible. That said, I mean, I can't help but be skeptical. And there's a lot of these programs that are dependent upon getting money out immediately or very quickly, whether it's, through small business assistance, individual loan, individual checks and support, or support for the hospitals. And I think that's, to answer that, you'd have to sort of decide for yourself how much confidence do you have in the ability of this administration to get things out quickly.
All right, great. I want to ask Billy one specific question around Medicare and Medicaid. We've seen, as you noted, a lot of regulations around Medicare and some on Medicaid as well. Obviously, CMS can kind of take a nationwide approach with Medicare, but on the Medicaid front, how do you see that playing out as far as the state response to COVID-19?
Yeah, I mean, I think it's kind of the federal list regime, in action here. It is, especially with regard to Medicaid and with regard to the state-based exchange, states. It really is going to be up to them, and therefore kind of the political processes and influences in those states to make those determinations. I think I'm just looking now at a recent list. I think over half of the states have applied for Medicaid waivers and have been granted Medicaid waivers to relax some of those provider and enrollment and eligibility criteria. So we see a very strong trend. And looking just quickly at the states, it's a diverse, geographically and politically array of states. So I feel confident, that states will respond despite there being, definitely unique approaches taken by each one.
Great, thanks. So we are just about out of time. What I'd love is for each of you to take about 30 seconds. If there are 1, 2, or 3 things you think we should be looking for in, potential future phases of COVID legislation, if you could prognosticate a little bit, and then we'll go ahead and wrap up. Andy, you want to take a first crack at that?
Great. Well, I'll just jump real quickly. I think that, there are a lot of people in Washington that are just going to sigh some relief because these last 2 weeks have just been so incredibly hectic in terms of pace. And as Congress passes the bill, they're going to be sort of hoping that things slow down for a bit. But I don't think they will. I think that starting Monday, if not sooner, we immediately begin the work on getting the administration to interpret these new laws the way that your organization hopes they will. There's no doubt going to be some loose language and perhaps drafting errors in what was hastily done, meaning an awful lot of authority and responsibility to the administration under very distressed situation to circumstance to get it right. And then we immediately moved to COVID-4. And I think if there's one thing we've seen so far is that this trajectory has just been faster and more dire than we've expected. So even though Congress expects to be out of town until April 20th, we imagine that when they return at the end of April, there will probably be some urgent needs in industries and sectors that we can't even predict right now that they'll have to get to work on.
Thanks. Billy, any thoughts?
Billy, I mean, I totally agree with that. I think that you will see a lot of legislative development over that recess period. Obviously, we're seeing House Democrats begin to float ideas on what would be in that Phase 4 package, as Andy has noted. I think it is going to be a daily, minute-by-minute stream of implementing regulations and guidance and grant opportunities from the agencies as we try to respond to this. I just wanted to note one quick thing. I know that there was a question about the MFAR proposal in the administration had issued before COVID took place, and this was a restrictions on use of provider taxes and fees and other things that states were using to draw down additional federal funds. The status of that regulation is in question. I'd keep an eye out for debate about that in the coming weeks. The Pelosi package from earlier this week included a 2-year ban on implementation of that regulation, but so far the administration's been mum on whether or not it would proceed. It could have implications on states' ability to manage increased Medicaid enrollment.
Great. Well, that is unfortunately all the time we have. Thank you both for enlightening us on a huge array of information over the last 30 minutes. And I'm sure we'll be back in touch as things continue to develop. So for our audience, thanks for sticking with us, and thank you so much for your participation and your great questions. Please take the time to complete the brief evaluation survey that you'll receive immediately after the broadcast ends, as well as via email later today. And you can view the full event video and transcript on our website, along with all the other videos from the COVID-19 webinar series. Andy and Billy, thank you again for joining us.
Pleasure. Thank you. Thanks, everyone. Be safe.
Great. Thanks, everybody. Be well.